Good morning, everyone. My name is Geoff Coombs. I'm a master's student at the University of Ottawa in Canada. I'd first like to thank the Aspetar organizing committee for giving me the opportunity to present today. And I'd also like to thank my co-authors, Matt Kramer, Nick Ravanelli, and my supervisor, Dr. Ollie J., for all their assistance and direction. So today I will be presenting the study that I've been working on for the past 4 months or so, which is entitled, Does acetaminophen alter core temperature and sweating during exercise in hot, humid conditions? So non-steroidal anti-inflammatory drugs are popular among endurance athletes and recreational runners and cyclists alike for its pain relief. And another similar drug, acetaminophen, also known as paracetamol, has been shown to improve cycling performance due to its analgesic properties, which elevate the pain threshold for exercise-induced pain. More recently, however, a study by Moser et al. In 2014, published in Experimental Physiology, has also reported that acetaminophen can improve cycling performance in hot conditions. Now, in this study, they attributed these results to the antipyretic properties of acetaminophen, which resulted in reductions in core and skin temperature, as well as thermal sensation. Although the results of the study were very interesting, the mechanism through which these results occurred remains unclear. This is due to the fact that the reported lower skin temperatures would not result in an increased heat loss. Also, the lack of sweating data available in this study is a major limitation, given the fact that the evaporation of sweat is our most effective potential heat loss mechanism. Furthermore, the data analyzed in this study was done as percentages of completion time, as illustrated below. So the figure on the left is core temperature in degrees Celsius, and the figure on the right is skin temperature in degrees Celsius, both over 10% intervals of time to exhaustion. This is from the Moser paper. So this is problematic when evaluating thermoregulation in 2 different trials of different lengths, because obviously the measured variables would have to be compressed from the absolute time in the longer trial in order to match the 10% intervals of the shorter duration trial. So this leads us to the purpose of the present study, which was 1, to determine whether acetaminophen ingestion truly reduces core temperature during exercise in hot, humid conditions, and 2, if so, through which heat loss mechanisms does this occur? So we hypothesized that acetaminophen ingestion would not enhance heat loss mechanisms, and 2, that changes in core temperature will therefore be similar between acetaminophen and placebo conditions during trials of fixed heat production and fixed duration. So far we've had 8 participants perform 2 experimental trials, which consisted of 60 minutes of upright cycling in ambient conditions of 35 degrees Celsius and 50% relative humidity. 60 minutes prior to the start of exercise, the participants ingested either 20 milligrams per kilogram of body mass of acetaminophen or the equivalent amount of a placebo. The experimental trials were performed in a randomized and double-blinded design, and the exercise intensity was set at a fixed heat production of 8 watts per kilogram in whichever happened to be the first trial, and the cycling workload was maintained in the subsequent trial. We measured metabolic heat production using indirect calorimetry, rectal and esophageal temperatures, skin temperature at 4 sites, local sweat rates using ventilated capsules on the upper back and forearm, whole body sweat losses from pre and post body mass measurements, and we also estimated skin blood flow using laser Doppler flowmetry. Here we have a summary of our resting results. So it is evident here that between the acetaminophen and placebo conditions, we have no differences in our resting rectal temperature, resting esophageal temperature, and resting skin temperature. We also have 2 perceptual measures here, which are thermal sensation and thermal comfort, which also presented no differences between conditions. So these results go to show that after acetaminophen ingestion and a 60-minute baseline period, there is no sort of any pre-cooling effect from the acetaminophen, and also that during each trial, the participants were beginning exercise from the same point. Now, if we think about some possible reasons why acetaminophen could reduce core temperature during exercise, the first might be that metabolic heat production is reduced, so due to an increase in mechanical efficiency. So as we maintain the workload between trials, we can also see that the metabolic heat production is almost identical between conditions. So therefore, there's no increase in mechanical efficiency, and we also know that there's no reduction. A reduction in metabolic heat production is not responsible for any reductions in core temperature. So the next logical thought would be that there must be an increase in heat loss in order to reduce core temperature. So we have here our mean skin temperatures during exercise, which also present no difference. Therefore, we can safely say that there is no increase in our dry heat losses. And furthermore, we have very similar whole body sweat losses between conditions, therefore suggesting that there's no enhancement of sweating during exercise. We also have three perceptual measurements during exercise. So we have our thermal sensation, thermal comfort, and perceived exertion, which again resulted in no differences between acetaminophen and placebo conditions. Now, it follows that if there is no changes in metabolic heat production or in heat loss, then we should not be seeing any changes in core temperature different between trials. So we can see here we have our changes in rectal temperature in degrees Celsius throughout exercise on the left, and on the right we have our changes in esophageal temperature in degrees Celsius during the 60-minute exercise period. So it is quite obvious that in both cases, the traces for each condition are almost identical, so we're not seeing any differences in core temperature change between conditions. In further support of this point, we have our local sweating data here. So the figure on the left is the local sweat rate from the forearm in milligrams per square centimeter per minute over the 60-minute exercise period. And again, you can see very similar traces between the two conditions. And then the figure on the right is our local sweat rate from the upper back in milligrams per square centimeter per minute. And it's almost identical traces between conditions. Now, as I mentioned, there is no differences in whole body sweat losses or local sweat rates. So in addition to this, we plotted on the left local sweat rate from the upper back in milligrams per square centimeter per minute over our changes in esophageal temperature in degrees Celsius. So visually, we can see that the plots from each condition follow almost the exact same trend. But furthermore, the table on the right presents the onset threshold and thermosensitivity values of the local sweat rate of the upper back. So you can see from these values that we also found no difference between the sweating onset or thermosensitivity. So this tells us that there's no influence of acetaminophen on the physiological control of sweating responses. Finally, here we have our skin blood flow data, which we estimated during exercise and normalized to a percentage of maximum skin blood flow. So on the left, we have the skin blood flow data from the forearm, and we can see, again, very similar traces between conditions. And then on the right, we have our skin blood flow data from the upper back, which is also very similar between conditions, although a little bit more variable. So the skin blood flow results here suggest that the distribution of heat stored within the body in conjunction with our similar core and skin temperatures is not altered by acetaminophen ingestion. So in conclusion, the preliminary data from the present study shows no difference between conditions in any of the measured variables. So this evidence suggests that acetaminophen ingestion does not mitigate physiological or perceptual indicators of thermal strain. Therefore, performance benefits following acetaminophen ingestion may result from the analgesic rather than antipyretic effects. I'd just like to acknowledge my fellow thermal ergonomics laboratory students, as well as our funding agencies, NSERC and the University of Ottawa Faculty of Health Sciences. Thank you all for listening.
Thank you very much for the nice talk. Is there anyone who would like to ask a question?
Hi, Lee Taylor from the University of Bedfordshire in the UK. Thanks very much for your talk. Just interested in your resting core temperature for your subjects. Ottawa's pretty cold, and the resting core temperature about 36.6, if I was right. I was just wondering the heat acclimation status of those guys.
All the participants were Canadian residents, and data collection was performed in winter, so I think it's safe to say that there was no acclimatization.
Had they participated in any studies previously?
Yes, previous studies, but at the time that it was performed, the participants who had previously participated in studies had not done so recently.
So what's recent? Basically, want to know what was the last time they were heat acclimated, for instance?
It probably would have been a few months before they had participated in a study involving exercise in the heat.
Okay, thanks.
Okay, Andreas has another question.
Thank you very much. Very nice presentation. I was wondering about the pharmacokinetics of the substance. Are you familiar with it? Why did you choose 60 minutes after ingestion?
From my understanding, I think peak plasma concentrations are about 30 to 60 minutes for acetaminophen. It also follows with the literature that I had read previously. So previous studies have done baseline periods of about 45 minutes. So just in keeping with that, as well as peak plasma concentrations, we chose to use 60 minutes. As well, we chose 60 minutes instead of the 45 done in the Moser, just to get a bit of an even longer baseline period in which we could determine if there's any sort of pre-cooling effect before exercise, even more so, which we did not find.
Okay, no, excellent. And just one comment, if you might find it a bit useful maybe to view things from a thermal and non-thermal point of view, because antipyretics are usually used for a non-thermal stimulus, so in this case a virus or something else, whereas you're looking at a thermal stimulus, so maybe it would be useful to view it from a thermal versus non-thermal viewpoint. I mean in terms of the paper, when you write it up.
Okay, thank you.
Any other question? Otherwise, I would like to ask a question in regards to your rationale. You presented the study, initial study, and there were some differences in core temperature with acetaminophen. It was in your rationale for the study.
Right.
But if you account for the difference in resting temperature, the delta in that study would be identical in the two conditions. So I didn't quite understand the rationale for your study.
You mean in my introduction where I
Yes.
was talking about the Moser paper?
Yeah. Yes.
Do you want me to go back to
Yes.
it in the slides?
We have 2 minutes
Okay.
extra. So you went fast, and so we can go back and ask. Yeah, that one.
So you're talking about the figure on the
Yes.
left, right?
If you calculate the delta increase in core temperature in the two trials, probably that's identical, because the difference between the two trials is basically identical. It's about probably 0.1, very close to actually yours. It was not a statistical difference. But
What I find interesting here is that I see your point from the rest to 100%. It looks like the change is the exact same. But I also, to me, it looks like at rest, the acetaminophen is slightly lower. But then when we have our end exercise point here, the acetaminophen and placebo trials are the exact same end exercise temperature, core temperature. So I'm not sure. I just find it interesting, and I'm not sure how these results occurred, which is kind of what stimulated the idea to retest this idea with our protocol.
okay.
Without using percentages to time to exhaustion, which I don't think is necessarily the most appropriate way to analyze this
It is
data.
a moment for Jay, if you want to clarify a point, and then Lars have the last question.
Sorry, I believe that the study that we based this on was a performance study. So the durations were
Yeah.
Okay.
There were different rates of heat production.
No, the rates are almost the same.
I know, but the thing is, that's the percentage of time to completion. So it was a performance study, and it wasn't a fixed heat production. So
Okay. Okay. Thanks for clarifying. Last question, a short one, Lars.
I don't think it would be fair for Geoff that he should account for the Morgan study because it has so many flaws that it wouldn't be. No, but I agree that it looks as if the delta is the same, and also when we saw your data, it appears that, let's say that the paracetamol or the acetaminophen that you use actually has this delta of lowering the starting temperature to 0.0 or 1 or something like that. It looks also in your data, you said you have n equal 8 now. Have you calculated the power? It looks as if you could get a significant if you had n equal 16 or something like that. So it could be a...
Do you mean in the...
Yeah, it's just you showed us the data that the resting...
that was slightly different?
Yeah, it appears that with n equal 8, you would say, well...
Okay, Lars, it has to be a short question. Now we'll
Yeah,
have to.
sorry.
It was a long one.
We plan to test a few more people, but I think maybe going 16 or above might overpower.
You haven't
the study.
calculated
I haven't calculated power, no.
Okay, do that.
But we don't want to overpower the results either, and find a difference where there may not actually be one. Because right now it's about a 0.09 difference in resting core temperature, which it's not statistically significant right now, and I don't think it's also physiologically significant as a difference in resting core.
I think we'll move on. We could spend a lot of time on this on the initial study that you didn't conduct. But okay.